Up next, we will have Professor Dr. Robinson George to present an article to sacrifice or salvage diabetic ulcer severity score in predicting prognosis. Please, sir.
International Journal of Surgery. I'm a professor and chief department of surgery in Pushpiri Institute of Medical Sciences, Kerala. We wanted to know the prediction of the prognosis in a diabetic ulcer and whether to sacrifice or salvage the limb. Foot has a basic introduction. The prevalence of the diabetes mellitus is exploding worldwide, as you know. India is as of now the diabetic capital of the world, with 30 million of the population with diabetes and a predicted score of 57 million by 2025. The WHO defines a diabetic foot as an infection, ulceration, or destruction of deep tissues associated with neurological abnormalities and additive peripheral vascular disease problems. Now, as you see, the diabetic foot is not just a disease, it's a syndrome. So, there are multiple variables in which we have to tackle. Basic anatomy, the foot is an integrated complex of bones arranged in beautiful arches. Now, this simple, beautiful arch maintains our grace and the equilibrium of our body. So, just imagine a foot where this is lost and thus the equilibrium. Foot ulcers are the most common complications that we see in our practice, with more than 60% of the lower extremity amputations seen in diabetic patients. The basic pathophysiology, I'll just rush through it. Development of an ulcer usually has 3 stages. Initially, we have a presence of a callus. We have 3 types of neuropathies. We have sensory, where the sensation is lost and it happens as a wound. Drying of the skin because of autonomic neuropathy is also another contributing factor. And last, motor neuropathy, where there is destruction of the tissues. And finally, the trauma comes in and forms an ulcer. So what me and my colleagues wanted to do was, we have since ages on ulcer grading systems, of which 2 are classics. One is the Wagner system and the other one is the University of Texas San Antonio system. Now, the Wagner system has 5 grades of ulcerations, of which it doesn't assess the depth of the ulcer. So we shifted on to the University of Texas Antonio, which we still follow sometimes. Here, what these guys have added are the infective elements and ischemia, so which still wasn't enough. So then we wanted something else. So we went into something what's called a DUSS score. It's a diabetic ulcer severity score, and this was what we thought of validating in our study. We have 4 clinical parameters. This is a very simple score which can be easily replicated and reproducible even in the most rural of sectors. As I tell my students, there are 4 P's. The first P is the position of the ulcer. That's the site of the ulcer. 2, palpable pulses, peripheral vascular disease obviously. And 3, probing to bone. It's with a skin probe instrument that we usually see if the bone is involved, and hence osteomyelitis. And the last one, the presence of ulcerations, single or multiple. The methods that we used, the study was published during the lockdown, that was around 2020. So it was around 300-350 patients. Now we moved on to 1500 and 2000 as of now. The inclusion criteria, all diabetic patients 30 to 80 years and the ones who were willing for the study. Exclusion, all the venous ulcers. We have calculated the DUSS score, which is there in the next slide. We have followed the wound therapy, standard therapy for all patients according to the usual general protocol. That's infective cases, we deal with it with antibiotics, wound debridement for deep ulcers. We've kept the patients on follow-up for a minimum of first fortnight for 1 month, then till the ulcer has healed, a minimum period of up to 6 months. This is the DUSS score that we've been following and we've validated in our practice with the 4 P's. This is the age-old Wagner system that we've been following. These are the few results of our study that we've published. The most common age group was between 51 and 60 that we had. Males were commonly affected with the 54%, is a bit technical. Most common ulcers were of the DUSS 2 category. So we've had presence of ulcers and palpable pulses in it, followed by DUSS 3. 42% of patients underwent amputations in our study. Thankfully, 30% of them were minors. The minor amputations were just toe digits, and the majors, what we're talking about is the joints above or below knee. These are the rest of the studies. The 2 main factors, the variables that we got after the validation of our study, was the probability and prediction of the healing of the patients of the ulcers, and the second point, how much of it will go into amputation. So this is what we had of this. The probability of healing among the DUSS were 100% for DUSS 0, 97.9 for 1 and 83 for DUSS 2. The healing period took almost 4 weeks, that's almost 1 month, which is good enough. The ulcers with low DUSS score had a low risk of amputation as validated by the original study of 1000 patients by Beckert et al. This is the take-home message that we have. The most important of this is the education of the patients. The simplest thing possible, because prevention is better than cure. As the patients have been made aware of the importance of near perfect glycemic control, proper care of the foot, avoiding tobacco, and the need for frequent follow-up examinations, we can actually reduce the enormous morbidity and mortality that is dealt with the loss of a limb and a very good quality of life. 2. An interprofessional approach is essential for all diabetic ulcer patients, which starts with a primary care physician, first and foremost. They refer it to a podiatrist, and third, where we come in, is a general or a vascular surgeon, preferably. And fourth, most importantly, in rural setup to an ultra-modern setup is a well-trained nursing care staff who deals with these dressings. For the antibiotics, which is usually not required if the treatment and the prevention is done earlier on. Please remember, the ulcers are always a common risk factor for lower limb amputations, and this is our job to salvage and not sacrifice the limbs. Thank you. And your questions, please.